Hello students, already we have been completed half of our physiology revision and MCQ discussion part before. So continuing in that part, here we have physiology revision 2. I hope you all would be studying very nicely, and till now are most probably on the whole approximately 90 days are left for you without including your December days. That day in the last times whatever we have to do revision and whatever the last minute revision, we would be preferring you that as well. But in times of now, the gradual revision along with the rotational revision of solving MCQs, whatever you have been prepared and whatever you have been studying so far is very important. So however you read and however you do revisions, but how weak you are and how good you are in which point of view, you can get it over whenever you solve MCQs. So if you solve MCQs, try to find out the weakness of your topics where you are and just note down the topics wherever you are weak and whatever you're getting to forget again and again. That is very important. So after that, if we see, most probably in your revisions and in your solving of questions, the mistake what you do is you would not see the question again whichever you have got wrong. That is important. If the question which you are getting it wrong again and again, just note it down this topic in a small sticky notes and just stick it down somewhere wherever you see daily and routinely. Then if you get to see those concepts and see those small point outs, then it will be registered in your subconscious mind, so no need to worry about that. So doing revision is important, but how you are doing the revision smartly is even more important. So starting with our 11th question, the resuming question, where we are resume over there. So all of the following decreases on standing from supine position except. So here all of the following decreases except also they can be giving for you. But here they can given you to twist you to think about how it makes much sense during standing from supine position. Okay. So the supine position the patient is, again they were standing, means what would be the possible reason which would be decreasing and which is in exceptual way they are asking. So option A, cardiac output, option B, total peripheral resistance, option C, central venous pressure, and option D, stroke volume. So what would be the most correct answer? Here I hope you people would be getting those questions and solve those questions before itself. So here the correct answer is total peripheral resistance. So how it could be the answer? Because they have been asking for decrease. Whenever you stand from the supine position, the resistance over your peripheral rims get increased. And moreover, if we speak in view of cardiac output, so you know what is cardiac output? It is a volume of blood, right? The volume of blood that is ejected during each cycle, or else you can say during each ventricle gets ejected. So per minute if we see, so the cardiac output is equal to stroke volume into heart rate. So if you wanted to know what is stroke volume, already from our cardiac cycle definition we know that stroke volume is the one which gives a volume of a blood. It's a volume of blood that is ejected by each ventricle per beat. By each ventricle per beat. So this cardiac output is nothing but ejected on the whole per minute. But this stroke volume which we are finding is for per beat in the cardiac cycle. So this is the stroke volume. So we can say if stroke volume increases, obviously cardiac output increases. If cardiac output increases, obviously heart rate is also increases. In this, you have to know that cardiac output is indirectly proportional or inversely proportional to your peripheral resistance. Peripheral resistance means the resistance that is given by your limbs. So if it is indirectly proportional, so cardiac output if it is decreased, or everything if it is decreasing, the one which is getting increased, that is your total peripheral resistance in view of cardiac output and stroke volume you can say. So central venous pressure, most probably it would be decreasing. So that is why your cardiac output is also getting decreased whenever there is a draining of blood from your superior vena cava and inferior vena cava is getting decreased. Okay. So the next question which we are going to say is, during the cardiac cycle, the opening of the aortic valve takes place at. So the options are beginning of systole, end of the isovolumetric contraction itself is, it also mentions systole, end of the diastole and end of diastasis. So aortic valve takes place. When does that opening takes place? So here I wanted you to remember a consequence. The sequence of the thing happens in cardiac cycle. Startingly there will be AV close. Then if AV is closed, then what should be open? Then semilunar valves should be open. So if semilunar valves are open, then obviously then they should close again, which causes AV valve to open again. So this is the sequence which is happening in your cardiac cycle. So how it is making much sense means your AV valve close in your systolic period, and especially when it is happening in your isovolumetric systole period, and that too in your ventricular system. Okay, so if we can see these two things like AV close and SL open happens in your ventricular systole, and semilunar close and AV valve opens in your ventricular diastole. So that too in ventricular diastole, especially if we are speaking about AV valve opening, that happens in ventricular diastole proper. So we know that in ventricular diastole there are four things. What are all the four things? In ventricular diastole, first we speak about the protodiastole, right? Yes. Then we speak about the isovolumetric diastole. Then we speak about the ventricular diastole proper. Then we speak about the rapid filling phase. So once at all the relaxation is done, there is no blood for ejection further. So further it is being filled very fastly. That is called as a rapid filling phase. In this phase, how much is the blood which is filled? That you have to remember, that is about 70% filling will be there in your ventricular diastole. In your ventricular, starting from your atrial systole, in atrial systole there will be filling of 70% of ventricular filling. So whenever the atrium get contracted, the ventricles will be filled with 70%, most probably, that should be remembered. So here the most probable answer is during end of the diastole, and if there is an option, if they have given an option of ventricular diastole proper, then that would be the most probable answer. Please remember that. Yes. So this is the all over cardiac cycle, this sequence which happens starting from your AV close, then your semilunar valves open. Further this leads to the semilunar valve close in which part? In your ventricular diastole part, starting from your cardiac cycle. Please remember that. So the next question is, maximum peripheral resistance is at. So it is regarding your arteries, arterioles, capillaries. Yes, by seeing the options you can get to know. Option A is arterioles, option B capillaries, option C small arteries, and option D aorta. So what will be the correct option here? Yes, the correct answer is arterioles. Why? Because the main function of arterioles are resistance. That is why it is called as what vessels? Resistance vessel. Important. In short, capillaries are called as exchange vessels, isn't it? They are called as exchange vessels. Your arteries and your arterioles, which is coming under them, are like vessels which is involved all of your Wind-Kessel vessels, which is coming under your aorta, right? This aorta will be coming under of all of your most probably big arteries, the pulmonary arteries, aorta, all coming under your Wind-Kessel vessels. The main thing of these Wind-Kessel vessels are they are elastic in nature. That is why they generate a kind of a pulse whenever there is a too much of blood flow, and whenever there is a less blood flow. Regarding that pulse, we can get to know the feel of the arteries. That's why the reason we are feeling the pulse easily in the arteries because of its elasticity. So in view of arterioles, if we are speaking about their resistance, they have a precapillary sphincters within them. Why these precapillary sphincters are used? For determining their flow. Especially in your arterioles. So these precapillary sphincters are used for that. So capillaries, as you all know, it is an exchange vessel, and also one more important thing is they have a gaseous exchange also. And mainly these capillaries, in view of capillaries if I am speaking, they are mainly made up of endothelial cells, right? These endothelial cells are them, and also these capillaries have 5% of total blood volume. Important. This is a question also which is being asked before. And one more thing you should know is the blood flow in capillaries is always the slowest. Always the slowest. So capillaries will be having a slowest blood flow. So that is also important in view of capillaries. So these are all the main important things you have to know in view of arteries and capillaries. We have a flow also, a flow of pathway which you have to know. This is a flow, or you can say the order of blood pressures regarding the vessels, order of BP, like in blood pressure. Starting from your aorta will be having highest blood pressure. Then your big arteries will be having a highest blood pressure. Then your arterioles will be there, right? Arterioles. Then you have a meta-arterioles. By that way, it will be coming to your capillaries. Then that comes your vena cava. So veins. Before that, there is a venules which forms a shunt vessels. So speaking about shunt, we'll speak that also. So venules, veins, and then vena cava. So vena cava is having a very least blood pressure, that is 2 mmHg, and in aorta you know that it is of 120 mmHg, and also that is why our BP normal is 120 by 80 mmHg. So in view of shunt vessels, what you have to know is where they have the arterioles and the venules meet together, in between them there is a shunt where the oxygenated and the deoxygenated get mixed together, and these shunt vessels play a main role in thermoregulation, the heat regulation. So this is also an important thing to be remembered in view of vessels. So the next question is mean arterial pressure is equal to, it's a kind of a direct question, direct answer you can give for this. That is equal to systolic plus diastolic pressure by half, or diastolic plus 1/3 of pulse pressure, systolic plus diastolic pressure by third, or systolic by plus 1/4 of diastolic pressure. So and the most correct answer is your B, that is diastolic plus 1/3 of pulse pressure. So how can we find this? You know systolic blood pressure is 100 to 120 mmHg, isn't it? So if we see that diastolic blood pressure, that is of 70 to 80 mmHg in average. So what happens in pulse pressure? PP is pulse pressure. You have to minus your systolic to diastolic, right? So 100 minus 70. Sometimes what happens? Your the most probable average thing would be like 30 to 40 mmHg. It will be, because we are taking an average value, isn't it? So if we see that in view of pulse pressure, if we calculate mean arterial pressure, that is equal to diastolic plus 1/3 of pulse pressure, which will be most probably 95 to 100 mmHg. And the textbook of Sembolingam says that it is 95 mmHg. So this is the basic thing you have to understand in an average value. So in the textbook of Sembolingam it is different, and Gautam it's different. We no need to go that detail. It's an average. No one cannot say that 120/80 is a perfect normal blood pressure for a human being. Nowadays WHO said like 140/90, even if it is normal because of this modern world and the food and the dietary medications. Everything apart, now the average mean value and the mean arterial pressure can be calculated by this formula of diastolic pressure plus 1/3 of your pulse pressure. Very simple. The next question is, which of the following is not caused by sympathetic stimulation? Sympathetic stimulation is not caused by. So first option, increased blood pressure, increased heart rate, increased total peripheral resistance, and increased venous blood storage. So which is not probably will be the sympathetic stimulation, right? So most probably we already know in view of blood pressure, in view of heart rate, if heart rate is increased, obviously your blood pressure will be increasing, right? Your cardiac output will be increasing, and we know total peripheral resistance will be decreasing, but it doesn't mean it comes under sympathetic stimulation. So here the correct answer is increased venous blood storage. Why? Because if venous blood storage is high, then there's not a possibility of the sympathetic stimulation will be there. That venous return or the venous storage will be less in view of sympathetic stimulation. In sympathetic stimulation, heart rate will be high, your blood pressure will be high, your venous return will be high, in turn your storage will not be high. Okay, it will never happen. Your venous return will be high, which makes your heart rate to in turn become higher. Because of all these things, your total peripheral resistance, which is inversely proportional, will be decreased. So this comes under your sympathetic stimulation, and this will not equalize and gives the meaning of blood storage. Venous return is different, venous blood storage is different. Venous return in the sense the superior vena cava and the inferior vena cava, whichever draining the blood to your right atrium, will be draining on. You know that both of your vessels like superior vena cava and inferior vena cava don't have valves, isn't it? They don't have valves within them. So until and unless there is no valves, how can they store the blood? How can the blood stored in your right atrium? It will be flowing on further because of your cardiac output is high, because of your heart rate is high, because of your stroke volume is high, and that is why venous return is also high. That will be giving blood further on. There is no point in blood storage. So that is why it's the right answer. The next question is, the concentrating ability of kidneys are impaired by. The concentrating ability of kidneys are impaired by. First option, damage to the glomerulus. The second option is excess secretion of ADH. Third option is extremely active sodium potassium pump. Increase in blood flow through vasa recta. So speaking about the concentrating ability, here the right answer is increase in blood flow through vasa recta. Why and how? See, in the concentration part, in the concentration of urine in kidneys, you have to remember one and only thing, that is counter current system. That is counter current system. CC in the sense counter current system. So what does this counter current system says? In view of counter current system, you have to remember only few things. They are having counter current multiplier, right? And they have counter current exchanger. So counter current multiplier will be working in your loop of Henle, and the counter current exchange works in view of vasa recta. So in loop of Henle, in the sense they will be in view of permeability to water, right? They will be permeability to water, means they'll allow water to move on, and there will be impermeable to other solutes. So permeability of water, they will give on all the water contents, and other solutes are not over impermeable. And one more thing, urea secretion is here, happens here in your multiplier system, where many of the solutes gets multiplied, in which they are not impermeable, and they will not go into the circulation again from your loop of Henle. If speaking about your vasa recta, the same thing which happens in view of difference, that in ascending limb what happens, same like this counter current multiplier, there will be a exchanger in view of vasa recta, which makes the concentration of urine by permeability and impermeability, means the opposite vice versa will happen. That is how your concentration of urine will be done until and unless it will be reaching your collecting duct. So that is what given in the question. If at all they have been given in view of loop of Henle, if in the option there is a loop of Henle, then that is also to be considered. So here we have only vasa recta, so directly we can go with an answer of vasa recta, because impaired. Ability of kidneys are impaired by. So if there is too much of blood flow through your vasa recta can be filtering of everything, they exchange everything, and the multiple solutes gets disturbed. That is how concentration ability can also be disturbed. Okay, yes. So the next question is, under the effect of ADH, maximum fraction of filtered water is observed in. Okay, so option is PCT, DCT, loop of Henle and collecting duct. So what would be the correct answer? At any cause, even if it is in the presence of ADH, or if it is in the absence of ADH, or if it is in the presence of, or if it is in the absence of ADH. In two places, the maximum absorption will be by PCT. Very, very important question. It will not change at any cost. Comparing to all your proximal convoluted tubule, distal convoluted tubule, loop of Henle and collecting duct, the maximum absorption and the filtration water will be, fraction of filtration will be more, and the water or any content in your renal purpose of all the tubules, the maximum absorption is in your proximal convoluted tubule. Okay, so the answer here is proximal convoluted tubule. Very important. So apart from this, I wanted here to mention some point about ADH. In ADH, the antidiuretic hormone, what is the thing you have to know? The water reabsorption will be there, yes. So that's why they are confusing you by the a term which is given as water in the question. Whatever it is given, the absorption will be maximum in presence or in absence will be PCT, that you can remember. So water reabsorption is one of the important function, and they are permeable to water. That's why their water content are reabsorbed in collecting duct and distal convoluted tubule. So this is having some aquaporin channels. Remember, the aquaporin channels are present, and most over 1, 2 and 3 are present in your renal tubules, which are all the aquaporin channels, and aquaporin 4 is also there, which is not related to renal tubule, but it is related to your brain. Remember that. And also there is aquaporin 5, which is present in your salivary glands. Salivary glands, very important. So renal tubules are there, brain is there, salivary glands are there, and these all having under the function of your antidiuretic hormone. Very, very important. So what they will do, how they are increasing their water reabsorption? Because of the presence of the substance CAMP. Very important question. Because of your cyclic adenosine monophosphate, they have a function and the action of water reabsorption. In view of a vasopressin, so another name of your antidiuretic hormone, that is vasopressin, also works here by which receptor? By the V2 receptors, your vasopressin works. Right. So the next question is, the isovolumetric relaxation stops when? Means they are asking you in ventricular diastole. In ventricular diastole, when does the isovolumetric relaxation stops? When the ventricular volume changes, when the intraventricular volume changes, when the ventricular pressure falls below the atrial pressure, or the beginning of TB. So see, in isovolumetric relaxation, what happens? In isovolumetric relaxation, so before that, what is the before part of your isovolumetric relaxation? That is your protodiastole. Ventricular diastole starts over there. It starts by your semilunar valve close. So once the semilunar valve is closed, your starting of isovolumetric relaxation is also started. Okay, so this will be starting, and the rapid fall in your ventricular pressure will be there. The pressure fall will be there. Before the starting of your ventricular diastole, there will be a rapid fall in pressure. So because of the rapid fall in pressure, that makes your ventricle to fill up again, and then it will get relaxed again. That's why there will be a closing of your semilunar valves. So once the semilunar valves are closed, then there will be again rapid filling. Then they will again start their AV valve to be opening for the further functioning of taking off the oxygenated and deoxygenated blood to their respective areas. So what happens? This rapid fall in the pressure is very important for isovolumetric relaxation to done. And rapid fall in the ventricular pressure is normal. Ventricular pressure is normal to move on with the isovolumetric relaxation. But in question, can you able to see what they are given? Ventricular pressure falls below the atrial pressure. Below the atrial pressure means atrial pressure should also be there and ventricular pressure should fall. Then only the relaxation happens, which causes further contraction process of atria to be. If atria wanted to be contracted, then there should be pressure more than the ventricles. But here, if atrial pressure is below, then how could able to be relaxation will be happening? Then the relaxation will be stopped. So that is what the reason ventricular pressure will be falling below the atrial pressure. So this would be the answer over here. So you can think over in view of this also. Rapid fall in the ventricular pressure will be there. See, here is your ventricles. So ventricular pressure will be decreased. So once at all ventricular pressure is decreased, there is nothing else over there left. So it happens the relaxation. So diastole will be there. Relaxation is happening. So once relaxation is there, after the relaxation, semilunar valves get closed. Right? Your mitral valve and the pulmonary valve, your mitral valve and the bicuspid valve will be closed. Tricuspid and the bicuspid, both the valves will be closed. Then it leads to the opening of your which valve? Yes, your aortic valve and the pulmonary valve. So once it is open, all of the blood flow within them, they will be going to the respective areas for their the circulation of the blood, for their giving blood to the another areas in which pulmonary valve, where the pulmonary artery flows on, gives blood to your lungs, and this will be giving function to your all of your body function. So in between that, the ventricular pressure also falls below than your atrial pressure. This makes your relaxation to stop and then start the further contraction process, and the pressure is the main reason for them. T wave and P wave is nothing to do with the ECG changes here. Ventricular volume is also nothing to do with here, because whatever the volume are, pressure should be very important for the relaxation and contraction to be happening, right? So that is why this is the answer. The next question is volume determining preload. So which volume will be determining the preload? Answers are EDV end diastolic volume, ESV end systolic volume, both, and the ventricular ejection volume. So here I wanted you to remember the definition of all of the things. End diastolic volume, end systolic volume, and EF ejection fraction. So what is the definition first? End diastolic volume in the sense the volume of blood that is ejected, or you can say the volume of blood in each ventricle at the end of this diastole. So once at all the relaxation is happened, diastole is there. After that, how much volume is left? That is your end of the diastole, end diastolic volume. End systolic volume is nothing but each or the volume of blood in the ventricle after the end of systole. Ejection fraction is the thing whenever there is a blood ejector, which we will be calculating by stroke volume by end diastolic volume into 100, that gives up to 65%. If you see end diastolic volume, normal would be 120 to 140 ml. And what is your end systolic volume? That is about 50 ml. Okay, so these are all very important thing to be remembered in point of this. Preload in the sense before the contraction happens, what will be showing the volume of the blood. So the end diastolic volume will be showing the whole on preload before the contraction, how much the volume of blood is present. Means we have seen that in the end of diastole, how much volume of blood is present. Means suddenly after diastole, what is going to happen? Systole. So then your preload blood will be coming to your afterload. So what is present over there? After the end of diastole, whatever volume that is present, that is came before, that is loaded before in your heart for the pumping. So that gives your end diastolic volume, which is the volume that determines the preload. If at all they ask about the afterload, then that would be possibility of your ESP. Okay. Yes, and if they ask about the fraction, how much is ejected, and the volume how much is ejected, then that would give your ejection fraction. The next question is stimulation of baroreceptors leads to. So options are increase in BP and heart rate, decrease in BP and heart rate, increased intracranial tension, and all of the above. So here what is the correct answer? Stimulation of baroreceptors will be leading to decrease in BP and heart rate. So how can we able to say this? I'm mentioning it here as baroreceptors. There are two things in baroreceptors. If at all baroreceptors means the stretch reflex. Whenever there is an extra stretch reflex which is being received by your vessels, blood vessels, extra stretch reflex apart from the normal, then the baroreceptors are activated. If at all they are activated, they inhibit the VMC, vasomotor center, and they activate the cardiovagal center. So what is the importance of cardiovagal center? You know that in cardiovagal center everything is decreased. Your BP is decreased, your heart rate is decreased, and your cardiac output is decreased. So inhibition of vasomotor center, in the sense, that is why everything in your cardiovagal center, cardiovagal center means your PNS, parasympathetic nervous system, is involved, and your 10th nerve is involved, which means like everything is in rest mode. That is, BP is decreased, heart rate is decreased, and cardiac output is decreased. So this means your stimulation of your baroreceptors. If suppose baroreceptors are not stimulated, then what would happen? Vasomotor center will be higher, which is activated in though, and they are not inhibited. Means vasomotor center are not inhibited. In turn, they will not activate cardiovagal center also, which means there is a possibility the vasomotor center can be activated, which is not inhibited. BP can be increased, heart rate can be increased, and in turn cardiac output is also increased. So this is the reason how and when the baroreceptors can be stimulating. And these baroreceptors are also having some pressure change. We know that stretch of the blood vessel can activate baroreceptor. But what is the range of that pressure? That range of the pressure is 60 to 200 mmHg. If at all your blood vessel feels this kind of a pressure, then your baroreceptors are activated. Important. So the next question is, in gestational life, surfactant are produced by, it is a direct question, no need of explanation about this, right? In your surfactant, in your cells, in your pneumocytes, in your respiratory cells in lung, there are two things. One is your type 1 pneumocyte and type 2 pneumocytes. In type 1 pneumocyte cells, they involve in respiratory gaseous exchange, and type 2 are involved in your surfactant cells. Okay, this is very important in view of your gaseous exchange and surfactant cells, and the direct answer is type 2 pneumocytes. Very important to remember. And the next question is, pancreatic B cells are freely permeable to glucose via. So here is the GLUT1, GLUT2, GLUT3 and GLUT4. About the GLUT, I have given you a tabular column in the discussion of our part 1. By that knowledge, by that familiarity, you should answer this question, that the answer is GLUT2. Very simple. In one, already you know that RBC, blood-brain barrier, cornea, right, brain, kidney, placenta are all there. In GLUT2 we have pancreatic B cells, right, liver and intestines are there, small intestine are there, right. So same like that we have a rule, and all over given GLUT in your tabular column. Just please read it out again and again as well. Okay, yes. So next question is, which of the following characteristics when there is a blood pressure of 170 by 98 mmHg, muscle weakness is there, polydipsia, increased thirst is there for the patient, plasma sodium is increased, which means hypernatremia, and serum aldosterone is increased, means hyperaldosteronism, and potassium levels are also, potassium and the renal levels are decreased, which means they are in view of, yes, plasma potassium level and plasma renin levels are decreased, hypokalemia is there, right, and you have in view of hypernatremia, hypernatremia. These all will be giving a significant use of, right. What is the diagnosis? The answer is Addison's disease, Conn syndrome, Cushing syndrome, and type 1 diabetes mellitus. So what would be the answer for this? The answer here is, just if you can see one and only thing, hypokalemia is there, aldosterone levels are increased. So directly you can answer that it is Conn syndrome. Addison's disease, why it can't be? Addison's disease means you have to add the disease, means add the hormone, it will be hypoaldosteronism. In hypoaldosteronism, Addison's disease, there will be hyperkalemia. There will be hyperkalemia and there is a possibility of acidosis. Okay, acidosis will be there and insulin secretion will also be less. So these are all the characteristics in how Addison's disease along with hyperkalemia deals with. In Cohen syndrome, directly you can see that there is hypokalemia, which leads to your alkalosis part as well, which we have discussed in the first part of our revision discussion, where there is a difference between your hypokalemia and hyperkalemia we have given. The next question, this is a kind of a direct question. Actual renal plasma flow is equal to effective renal plasma flow of 0.9, effective renal plasma flow into 0.9, effective renal plasma flow into 0.7, and that is into 0.9. The effective plasma renal flow, that is 0.9, is the answer here. So even it is a direct question, 0.9 should be given over here. But if you know about the renal plasma flow, the basic formula is UV by P. What does it mean? The urine concentration along with the flow of rate which gives the volume by plasma concentration. So this is the basic rule, and that would be 645 milliosmoles per liter. So the effective renal plasma of 0.9, this is the derived and the simplified version of the formula which is given. And speaking by the renal plasma flow, if at all they have been giving the urine concentration value, the volume of urine which is present and the rate of their flow and the plasma concentration, you would be able to find the answer of renal plasma flow, and this is the formula for that, UV by P. The next question is ADH leads to reabsorption of. Please don't say water, because water can be reabsorbed by ADH, that is known. Here water and urea, water and sodium, water and calcium. You know sodium is involved in your aldosterone, isn't it? Sodium is for the involvement of your hormone aldosterone. If at all we are speaking about ADH, yes, obviously there is an involvement of your water, H2O. But the main thing is urea also involved in the reabsorption process. So the answer is water and urea. So speaking about ADH, we have just 4 or 5 questions back we have seen that ADH is having a capacity of H2O reabsorption. Even in the presence of them or in the absence of them, water is going to get reabsorbed. So if at all they haven't given this, then PCT will also be the answer for this, right? So they also have a capability of urea reabsorption. How in our counter current mechanism, especially in loop of Henle, urea is secreted. Too much of urea secretion, more than the needed amount, can be reabsorbed by the hormone ADH. So that is the balancer mechanism, counter current exchange system mechanism. Counter current in the sense whatever increased over there in the loop of Henle, that will be taken against inside by your vasa recta, then everything get equalized. This is how your urine get concentrated, and the concentration of urine is always depends upon the hormone ADH. If ADH is more, then what happens? If antidiuretic hormone is more, then the concentration of urine is also high. Why? Because all of the water present in the concentration of urine is reabsorbed. If ADH is less, then there is a dilution of urine. So if at all they ask the question, dilution of urine is influenced by, then your direct answer should be antidiuretic hormone, because of the water reabsorption capacity. And not even water, urea is also reabsorbed. So the next question is, a 35-year-old female was watching TV for long hours with hand under the head. So once her hand under the head is there, she will be keeping it for longer time. So she is keeping it for a longer time, but we doesn't even know how much time she has been keeping like this. She is having a touch and she is having a pressure also, too much of pressure if she is watching for so many hours. Then she complains of tingling sensation over the arm and she is feeling weakness. Which type of nerve fiber is most likely to be affected? This is the question which is asked in centralized PG exam once in a while. So that is the reason we have been giving this nerve fiber question again and again, so that it is easily founding you for you, like easy to found out even if they ask in view of clinical questions. So we have seen that A fiber as a mnemonic PSM, isn't it? So they have proprioception, they have somatic control, and they have a motor control. So if we see this, touch, they have a motor effect that is given by view of touch and pressure also. They have a sensational effect also, right? So that is why your A, alpha, beta, gamma and delta, which is giving your touch, which is giving your pressure, which is giving even the fine and crude touch, comes under A fiber. So the answer over here is your A fibers. Very important. So because of the touch and pressure of the hand, which is given by her head for a longer period of time seeing TV for a long hours, that could be the reason these nerve fibers get affected, and that is the reason why she feels tingling sensation over there. The next question is Bohr effect. On second, yes, Bohr effect is because of the effect of concentrate carbon dioxide and the effect of your H++ on oxygen dissociation curve. On both, C option, then the D is none of the above. So knowing about this Bohr effect, you should know two effects in your respiratory HB, means carbon dioxide oxygen dissociation curve. That is, one is your Haldane effect and another one is your Bohr effect. Bohr effect. So what is the important thing? In Haldane effect there is a left shift. In Bohr effect there is a right shift. In Bohr effect there is a right shift. Speaking about them, in left shift the HB is having more affinity to oxygen. Affinity to oxygen. So if at all we see, we have affinity in your Bohr also, but if you see in view of Bohr effect, affinity of hemoglobin in oxygen is less. Even though if it is less, that's why there is an unloading of O2 from HB. So until and unless the affinity is more here in your Haldane effect, there will be loading within them. Loading means the both get together, attached together, moving together. So because of this we can say that PO2 will be higher. Here PCO2, the partial pressure of carbon dioxide will be higher because of the unloading purpose, and that is the reason why PO2 will become less in the circulation where hemoglobin is transported. So in view of this, here carbon dioxide is there, but the dissociation curve within them is by the effect of which? Yes, it is of both. Carbon dioxide is also there. Here we will be speaking about your pH also and the H+ concentration also. So in view of pH is getting decreased. That is why it is acidosis in nature. In the acidosis point, your H+ will also be increasing. In this point, we are comparing about everything in the dissociation curve, even if it comes to Haldane effect or if it comes to Bohr effect, about your carbon dioxide, about your oxygen dissociation curve, about your loading and unloading and all the purpose within them. In view of this, if they ask you one more question over here, diabetic ketoacidosis DKA is perfectly explained in which effect? That is Bohr effect. Please remember. So the answer over here is both. Both effect are explained in our curve of Bohr effect. So next question is, cutting the vagi with the removal of upper pons leads to. So here vagus nerve is cut and the upper pons are also removed. So what will be the most probable answer? Option A, hyperventilation. Option B, hypoventilation. Option C, apneusis, and option D, none of the above. To know about this, you have to know the pathway of regulation of the centers of respiration. So that, for example, vagus nerve is there, which will be giving or which will be activating your apneustic center. But if you see in apneustic center, indirectly they will be inhibiting. Right? So because of this, inhibitory neurons are which inhibitory neurons causes inspiratory neurons to be activated. Eye cells, or you can say eye neurons. Inspiratory neurons are activated, causing inspiration. Okay, so this is having a function of inhibition in your apneustic center. So once at all inspiration is happening, after that this inspiration will make your stimulation of spinal neurons. in which further respiration along with the expiration happens. So after once inspiratory neurons are done causing inspiration, this causes pneumotaxic center to be activated. This pneumotaxic center causes what? Activation of E neurons. E neurons is nothing but your expiration is happening because of your E neurons, that is expiratory neurons. So further E neurons will be activating your expiration from your pneumotaxic center. So if at all inspiration and expiration is not being done in a normal manner, if any of the pathological abnormality, now here vagus nerve is not there. So no one is there to inhibit your apneustic center. So there will be a prolonged inspiration. The main thing, after once the inspiration is done, they have to be inhibited by vagus nerve. This is the normal thing. If vagus nerve is not inhibiting the apneustic center, they will be activated. The inspiration will be prolonged. That prolonged inspiration is nothing but your, yes, apneosis. So answer over here is, even if vagus nerve is cut, then upper pons will also not be there. The upper pons main involvement is your pneumotaxic center, so both are not going to be working. So your expiration is also affected, and also your vagus nerve is cut, which is going to inhibit your apneustic center, is also affected, causing apneosis, that is prolonged inspiration. That might sometimes cause inspiratory spasm. Prolonged inspiratory spasm. This will be like this. There will be a spasm of inspiration. So that is why the inhibition of apneustic center after the inspiration should be done, causing activation of your pneumotaxic center, in which expiration should happen. That is why the cycle of inspiration and expiration should be normal. Cutting off this might lead to prolonged inspiratory spasm. The spasm will be there. Inhibition will not be there by the vagus nerve, that causes spasm. The next question is, peripheral chemoreceptors responds to all types of hypoxia except. Option is anemic, histotoxic, stagnant and hypoxic. To know about this, you have to know about the two chemoreceptors. One is your central chemoreceptors and another one is your peripheral chemoreceptors. Seeing about the central chemoreceptors, the only one thing they are going to activate is your H+, protons in especially CSF. So we are speaking about central nervous system, the central chemoreceptors. That is why, because of the H+ ions present in the CSF, the central chemoreceptors are activated, and also sometimes H+ in the blood can also activate by peripheral chemoreceptors. So H+ in CSF is activated by your central chemoreceptor, and H+ in blood is activated by peripheral chemoreceptors. Seeing the peripheral chemoreceptors separately, what are all the conditions they can get activated? Your PCO2 if it is increased, your carbon dioxide if it is increased, or else you can say indirectly peripheral receptors can be stimulated by increase in PCO2 or if oxygen levels are decreased. In both the contents of hypoxia, peripheral chemoreceptors are stimulated. There are some exceptions. When the peripheral receptors are not stimulated. They are not stimulated if PCO2 is less. In kind of an anemia condition where HB is less, they cannot stimulate them. Even less hemoglobin levels cannot stimulate the peripheral receptors. And also one more thing, your carbon monoxide, CO, carbon monoxide, these three things will not stimulate your peripheral chemoreceptors. So the answer over here is your anemic hypoxia. The next question is, a 56-year male came to the emergency with a complaint of breathing difficulty along with the breathlessness. Saturation is fluctuated around 81%. ABG interpretation is done by the physician showing respiratory acidosis. Remember, the renal compensation of this patient is done by respiratory acidosis means, for example, pH will be acidic. It could be anything. The values could be anything. Just simply I am saying you respiratory acidosis will be presented like this. Your bicarbonates and your PCO2 will be there. PCO2 will be more than 40 mmHg, the normal value. The normal value of bicarbonate is 28 to 32. About bicarbonate they haven't mentioned over here. So this is your PCO2 is in a kind of a range of acidic, and your pH is also acidic, showing respiratory acidosis. To compensate this, what your renal system will do? See the first option, H plus reabsorption. If H plus is reabsorbed, it will make your pH to be even more decreasing, causing even more acidic. So H plus cannot be reabsorbed, which causes even more acidic to your metabolism also. And bicarbonates, sodium are secreted. It should be, if it is possible, bicarbonates, if it is secreted more and their reabsorption is not done, which also get decreased, causes acidosis. Secreted means in your tubules, renal tubules, they are getting secreted from the blood. They are taking the content like bicarbonate and they are secreting inside the tubules. Means then the circulation will be less of bicarbonate making acidosis. So that is also not possible. That will not compensate your metabolism and your process in respiration as well. Chloride reabsorption has nothing to do with your bicarbonates and protons, H plus. NH3 plus secretion, ammonia secretion in view of H plus. We have a presence of H plus ions in NH3, by which the renal compensation can be done. If H plus 3 is secreted more in your tubules, this H plus secretion can be happen in your DCT, in your collecting duct as well, sometimes in your loop of Henle. Most probably loop of Henle is a very least, but it can happen in your DCT and collecting ducts. This secretion can make your acidic level to be decreased. This decrease in acidic level in your metabolism and in the circulation makes the renal compensation for your respiratory acidosis. The correct answer here is NH3 plus secretion. Your H plus should be secreted until and unless in your process of respiration or in your metabolism acidosis is there. Means if we secrete H plus, means you are taking out the H plus from your circulation, means you are decreasing H plus indirectly by some other compensation. So this is what given in the all over question, how they can able to compensate them. So the correct answer is NH3 plus secretion. So this is the all overview, whatever we have seen in view of our questions. Like we have covered most of our physiology and most of our important repeatedly asked questions. These are not much difficult questions. No, don't worry. They are not going to ask you a very difficult question. They are just going to confuse you with a bit way of question they ask, but everything is same as before. The concepts that they are going to ask you are same. The hot topics that they are going to discuss within you are same. And the examiner point of view are same. The simple thing is you have to be sure in your answer, how you are going to select the answer. Just read the question, just see the option and then just go with the option which you feel first as right answer. Okay. So this is the all over discussion which we have seen regarding our physiology revision. So after this we would be doing revisions of other subjects as well. I hope your revision will be very fine and good. Don't think about anything, just go with the flow. Whatever comes and falls in your trap. All the best, just be prepared yourself. Thank you.